Hi, this is Nicole Kupchak, and this is 10 Minute Tidbits. Today, I'm here with
Joel Green.
And we are going to chat about part 2 of the PADIS guidelines. Okay, so let's quickly recap just what we talked about discussing our first segment.
With PADIS, first of all, what does it stand for? PADIS was designed by SCCM, which is Society of Critical Care Medicine, to assess pain, agitation, delirium, immobility, and sleep.
Absolutely, yeah. And then one other thing I just want to mention is I want to do a huge call out though. So the Society of Critical Care Medicine has kind of organized an international multi-professional group to kind of bring them together. And this is the second iteration of the guidelines. But really, when you go back and look at a lot of the literature, I think the group that needs the huge shout out is Vanderbilt University. Wes Ely, Brenda Pun, they have done so much amazing work at Vanderbilt, and they've just published gazillions of papers on delirium. And it's so funny, I saw Wes Ely at a conference last summer, and I always joke with him every time I see him and say, you know, Wes, you made delirium sexy, you know, because I think delirium's one of those things where we're just like, you know, it's ICU psychosis, whatever, just is what it is, people just get this. But actually, it's a big deal, you know, when patients get delirium. They're never the same. Right. You know, they're never the same.
Yeah, and having friends who have been patients in the ICU, they will tell you that the trauma, the PTSD they've experienced, the delirium they experience, just from medications, from routines, from being awake all the time, from pain, from stress, they said it's pretty intense.
It's not a little thing. It's absolutely not a little deal. And I know there's a nurse who I'm planning to interview who had pneumonia and got sepsis and got delirium, and it's been a rough recovery for her. And so, it's one of those things that we just, prevention is key.
Right.
It's absolutely key. But, when you look at some of so we're on the D of PADIS. So the first episode covered the P, pain, the A, agitation, and then we went into the D. But I want to kind of finish off the D, and then we'll do the I and the S. But, when you look at just long-term studies of patients who have had delirium, I mean, they struggle.
Yeah.
When
and it's a lifelong struggle too. Is that sounds may trigger them, similar to the same thing our military people experience with PTSD. Is there's still triggers that they have from that event because it was so traumatic.
Oh, absolutely. And I think, a lot of people have night terrors. There have been a few patients that have been in the literature that have actually dropped their IQ scores.
Wow.
After having delirium. I'll never forget Vanderbilt University interviewing a woman she worked in accounting and was really good with numbers, like that was her thing, and she was in her 50s, got pneumonia, sepsis, and had delirium, and then she after a number of months was rehabbing and got back to work, and she just couldn't do it. She ended up having to retire at much earlier than she thought she'd have to, and it has huge long-term effects. If you make it, right? Because that's the other thing, is the mortality is really high in the first year that patients have delirium. So
with the delirium, there is some things that they recommend. So we've seen some recommendations. One of those is less use of opioids, less use of benzos, and trying to find more ways to use less medication to get our patients back to normal.
Yeah. And and then we're going to get into the I and the S, because I think the I and the S are the key to prevention of delirium. Okay, so let's talk about the I.
Yes, so mobility in the ICU. So jokingly, mobility is medicine. That's one of the phrases that's like on the wall in our unit. And, but there are some units that are really good about mobility. We look at like cardiac surgery units, orthopedic units. Those units are on it because they find that the faster they get their patients up and moving, the faster they get their patients out, and they shorten their length of stay. So as we've seen those changes in those types of ICUs, we're starting to see that across the board with our medical ICUs, our other types of ICUs that are out there to get our patients moving.
Yeah, I think one of the most impressive studies I've ever read was out of the University of Utah. Dr. Schweikert did this amazing study where they randomized patients to either get kind of a usual care mobility program versus early mobility, where they got patients up within 12 to 24 hours from admission. And the statistics in this paper were stunning. When they looked at functional discharge, or functional ability at discharge, I mean, it was almost double if you got mobilized early, which is insane to me. You know,
and mobility doesn't mean turning every 2 hours.
No, that's not.
That is skin prevention and that's preventing breakdown.
Yeah.
Mobility is actually doing things like active range of motion, getting your patients up to a dangle position, to a sit position, or even stand or over to the chair. Getting your patients out of the laying flat or even the 30-degree or 40-degree
Well,
position.
there's no reason you can't do something on a patient. You know, especially most beds sit up to a chair.
Right.
You know, like that's the easiest thing in the world. Now, if you've got somebody who's crashing, hemodynamically unstable, bleeding out, that's not who we're talking about. You know, but if you've got
or the crazy person that's doing this. You know, slinking down the bed all the time. So you put them in the chair position and then they're out the bottom.
Then they're out the bottom in no time. Yeah, but I think, you know, the key is just some sort of mobility. There's this really cool, and I'll actually be posting a video probably in the next month or so. I'm going to go to the Society of Critical Care Medicine meeting, but this it's a cycle that you pull to the end of the bed, and patients can actively or passively or a combination cycle in the bed, which I think is brilliant. I mean, because we all know to get a patient up out of bed takes a few people.
It takes manpower, especially because these patients are weak.
It can be challenging.
They're minimum 2 to 4 people. So you can see a lot of changes, and some of our teams have implemented mobility teams.
Yeah.
But then again, that's a cost to the hospital whether or not we can do it. So you have to prove length of stay and grants and things like that to prove that you can have these teams available.
Kind of your return on investment. And it was interesting. A number of years ago, we had gotten a grant to get a physical therapist in the ICU to help us get patients up, and interestingly, she really couldn't do much because our patients were so delirious that we basically scrapped the grant, and then we ended up training CNAs to be physical therapy assistants, or I should say mobility assistants. Not PT assistants, but mobility assistants to help get patients out of bed, and I think that's key. But just remember, mobility can mean anything from a dangle to a chair position to just getting their feet on the floor. And I'll tell you, one of the things a lot of nurses were afraid, like, oh, my patient's on a little bit of norepinephrine, I can't mobilize them. Yes, you can. And in fact, if you get their feet on the floor, what does that do to venous return?
Increases venous return. It also helps with their equilibrium. And you'll find patients who always feel like they're floating because they're in the bed all the time and the air mattress is shifting. Sometimes that touch to the floor can help reorient them back to normal. Along your same lines of I can't mobilize my patient, if we can mobilize ECMO patients and walk them down the hall on an ECMO machine, you can mobilize your patient who's on 0.5 of epi or more epi.
I agree.
In cardiac surgery, we mobilize patients with swan lines and chest tubes and pacer wires, and they'll have 6 or 7 drips still on, and we will mobilize them. They will dangle, they will stand, because it helps them overall.
So the S in the guidelines was sleep. Okay, boy. So you work night shifts still.
I do.
Which I think he's crazy. He still works night. I did 14 years of nights. How many years have you been doing nights?
Off and on for 16 years now.
Okay, so he still works nights. So so let's say you come in a night shift. What's like the first question we all ask each other?
When are you having lunch?
Besides that.
That's my first question. When do you want to take your break and have lunch?
How'd you sleep last night? Did you, or this morning or today? Did you sleep? That's what everyone wants to know. Did you sleep? And what do we all say?
No.
Oh, it's terrible. I didn't sleep at all.
There's construction in the building. My neighbors were being loud. The leaf blower was out there.
All right, but can you even imagine being sick and in a hospital and not being able to sleep for more than an hour straight? I can't fathom it. And I think one of the things we have to do is start changing the norm. Why do you have a non-invasive blood pressure cuff going off every hour? I mean, truly, why? Is the patient on a vasoactive? Are they on a vasodilator? Are they on anything that does anything to their blood pressure? If not, can we change it to Q2 or Q4? I don't know. I just think we need to start questioning these things. And, and maybe a patient doesn't need vitals every hour to 2 hours during the night.
Checks.
Or Q an hour. Don't even get me started on that. like 3 days later after they're stabilized. I don't know. I think we just need to really challenge this. The detriments of not sleeping are huge.
Well, and I think too, it's your environment too. Like our environment is hard at the facility I work in because half of our rooms don't have all four walls.
Yeah.
We have curtains across the fourth wall, which makes it hard for noise. You have noise of the unit, noise of
Challenging.
nursing staff,
Yeah.
call bells, etc. And then you have like alarm watch. You have other patients screaming. You have smells. So how do you smells?
Cheerleaders.
So how do you fix those kind of things for your patient? And the nice thing about if you look at our current guidelines and our protocols, is that we can actually liberalize their vital signs. So if a patient's stable, we can liberalize to Q2 or even Q4 during the night to try and help routines with these patients.
Well, I think that's key because so many times in hospitals, why are you doing that? Well, because we've always done it. That's not a good. It's not a good reason, right? And the other things. Have you thought about like eye masks, earplugs, melatonin, even like what about some melatonin? Ambien's the one I would be questioning in hospitalized patients. I'm not really sure there's a place for that anymore. But but unless you want to walk around naked in the street, whatever. But no, I'm joking. But I think there are things we can do to promote sleep.
And I think like one of my friends, Lori McNabb, shout out to you. We talk about medication timing. Is when are our patients getting their meds?
Oh, 1 a.m.
1 a.m. And one of the things that happened was we are on a Q8 cycle of heparin. So yes, I'm going to come in at 1 a.m. and stab you with heparin in the belly. Not something patients really want you to do at 1 a.m.
It doesn't
and
have
so
to,
she looked at, can we talk to pharmacy and change the schedule? And now we're on a much better schedule where patients get their heparin.
What did you guys end up going to? Because I think a lot of nurses out there watching
we went to 9 and 5, which I still don't like. I wish we'd go to 10 and 6.
Okay.
So we may need to get a little bump one more direction. But with our hour time swing of medication, you can still do 10 and 6 and be on time. So.
Well, and I think the other thing is labs. I mean, come on, labs at 3 in the morning. Are you joking?
And there's some places that are like, well, I have to get it done by 3 so it results, and I've corrected all the electrolytes before day shift shows up and before the physicians show up. You don't have to do those things.
No, I agree.
Or
it's
time them with other
24/7.
activities.
Well, and the hospitals are 24/7.
Yeah.
I know one of the things that drives me nuts, because I was nights forever and then went to days, is I got the bath done. Like, why?
Yeah.
Don't, I'll do the bath on day shift, honestly. Like, don't wake these patients up, because I'd rather have to give a bath than deal with delirious crazy person, right?
Yeah. My personal rule is I try to get my baths done before 11, or I will do them after 5 a.m.
Yeah, I mean, it might actually help them sleep if you do it before 11. But that's just time-wise not always
Do you have
possible.
time to do it? Yeah, and it really is patient dependent. But I mean, look at your regimens. What are we doing? Or does my patient always wake up at 2 in the morning? Well, do their labs at 2 in the morning when they're awake. You don't have to wait till 4 or 5.
Yeah, no, I agree. So anyway, well, we would love to hear from you. What is your unit doing to decrease the chance of patients getting delirium? We'd love to hear from you. If you've got anything kind of cool you're doing in your unit, tell us about it. So, all right, I'm Nicole Kupchak.
And I'm Joel Green.
And this is 10 Minute Tidbits.